Hello, and welcome to today's webinar titled Applying the APA Guidelines for Psychological Practice with Trans and Gender Nonconforming People in Everyday Practice. My name is Ron Schlittler, and I'm the Program Coordinator at APA's Office on Sexual Orientation and Gender Diversity, and we're very pleased to be hosting today's webinar. I will start off with a few housekeeping comments and then hand it over to your moderator, Dr. Seth Pardo. This webinar was Dr. Pardo's idea, resulting from an APA Public Interest Leadership Conference in which he participated. The free CE and presenter honorarium were made possible due to a generous public interest directorate grant awarded to the Society for the Psychology of Sexual Orientation and Gender Diversity, Division 44, and the Committee on Sexual Orientation and Gender Diversity. There are no commercial interests being served on the part of any of those involved. All participants are muted throughout the webinar. And if you're participating for CE, you must be individually registered and you must complete the webinar evaluation within 24 hours after the presentation. A link to the evaluation will be sent out along with a recording of the webinar shortly after it's over. But be aware that due to a platform incompatibility issue, the link will not be live, and you will need to copy and paste it into your internet browser to access the survey Gizmo evaluation. Also, there will be 5 survey questions throughout the webinar, which will serve as our roll call for most participants, so please do respond to them. For those of you who are participating in small groups off of one computer, there will be a prompt about halfway through the presentation for a roll call. At the prompt, someone will need to enter the names of those participating in the questions field. There will be a Q&A during the last 15 minutes of the presentation. Please submit any questions using the Questions tab. And now I'm pleased to introduce your moderator, Dr. Seth Pardo, who will introduce your presenter, Dr. San Chang.
Good morning, everybody. Thank you for being here. I have the distinct pleasure of introducing you to Dr. San Chang. Dr. San Chang is a Chinese-American non-binary gender fluid psychologist, educator, and trainer based in Oakland, California. Dr. Chang is currently the program manager of the Wyland Health Initiative at Stanford University and the clinical practice consultant for transgender services at Northern California Kaiser Permanente. They also maintain a private practice specializing in trauma and EMDR, eating disorders and concerns, addictions, relationships, and trans health. San served on the task force that authored the 2015 APA guidelines for the psychological practice with transgender and gender non-conforming clients, and as the past chair of the APA Committee on Sexual Orientation and Gender Diversity. Outside of their professional work, San is a dancer, avid foodie, and pug enthusiast. It is my distinct, excited pleasure to introduce you to Dr. San Chang.
Thank you, Seth and Ron, and I'm so happy to be here and so pleased to have such a great turnout for this, and very excited to talk about the guidelines and how to apply them to everyday practice. I'm just sharing my screen right now just to say a quick hello, and then I am going to stop sharing my screen now and share my slides instead. So here we go. Okay, can everyone see the screen?
Yes.
Okay, great. Actually, I'm going to share the main screen just in case. Okay. Okay, great. So this is me. I'm not going to go over that, but yep, that's me. I'm going to start with an everyday example about challenging gender norms. This is an illustration. Is it a boy or a girl? Why does it matter? Here, let me look. This is inappropriate. Look, people, there are more than 2 genders. Some identify as boys, some identify as girls, and some identify as both, neither or somewhere in between. So do me a favor and stop asking that question. I always like to start with this just to remind us of how much gender training and the binary is ingrained in how we think about people, and how it really does take such a conscious effort to kind of flip the script on that, and that includes in our clinical practice. So the objectives today are to look at the rationale for each of the guidelines and describe 2 applications of the guidelines and utilize clinical skills. And so I'll be using examples with survey questions to sort of go over some case scenarios. So the first survey question is first to just get a sense of who's with us today. So how would you characterize your skills in working with trans clients? Novice, no experience, minimal, moderate, very experienced but need to learn more, and expert, nothing new to learn. And I'm going to give you just 10 seconds or so for each of these polls. We're going to kind of move quickly today through some of this because there's so much to cover.
Okay, I'm going to close the poll.
Great, thank you. So it looks like we have novice to very experienced folks, and I'm actually pleased to see no one chose expert, nothing new to learn. I think that was really tapping into a sense of humility, and that, you know, even those of us who've been doing this work for a long time, there's always more to learn. I will say that today the focus is more, it's not a 101, and there's a lot of very foundational material in the guidelines themselves. And so I'm not going to go over the sort of basic 101 level. I'm more looking at the applications. So yeah, so let's move on. Okay, so the guidelines, just a little bit of context. There are basically 5 domains. There are 16 guidelines, and this is how they're divided. And I'm going to go over each of them. So the first 4 are foundational knowledge, and the first 2 guidelines I've chunked together. And the first one is that psychologists understand that gender is a non-binary construct that allows for a range of gender identities, and a person's gender identity may not align with sex assigned at birth. So just really establishing that there is a difference between sex assigned at birth and gender identity, and there is a potentially wide spectrum. And guideline 2 is that gender identity and sexual orientation are distinct but interrelated constructs. And so some of the guideline 1 applications are to actively learn about different gender identities and expressions, and to assist our clients in actively challenging gender norms and stereotypes as well. And maintaining an open and non-judgmental stance, especially when we're unfamiliar. You know, I come across things that are unfamiliar to me all the time because things are constantly evolving, and really the goal is just to be humble and open and willing to listen and be challenged in some way. In terms of applications for guideline 2, we really want to help our clients understand the distinctions and interrelatedness between gender and sexuality, and normalize and validate a wide range of sexual orientations, getting away from any stereotypes around what it means to be trans or gender nonconforming and how that might dictate attraction, because really there is no one way to be trans, and yeah, it is a separate sort of but related spectrum. And I do want to just note that non-binary identities, they're not a new and Western phenomenon. So we see these things like gender revolution and hear that young people are changing gender, but this is actually, you know, there have been non-binary identities and gender variance or expansiveness dating back on every continent for centuries, and could be considered as predating non-binary identities themselves. Guidelines 3 and 4 are that we seek to understand how gender identity intersects with other cultural identities. So really taking a broad view and seeing the whole person, not just focusing in just on gender identity, to the detriment of looking at race, class, ethnicity, ability, religion, etc. And then guidelines 4, that psychologists really challenge and are aware of our own attitudes and knowledge of gender identity and expression, and how our own biases might affect how we work with trans folks and their families. I'm paraphrasing. And so in terms of guideline 3 applications, we really do want to encourage the exploration of cultural intersections and the relationship, not just, oh, these are, you know, multiple identities or intersectional identities. You know, we can't talk about intersectionality without talking about systems of oppression and the ways they afford privilege to some over others. And we want to identify and 8 areas in which clients feel conflict at times between different values they might have, feeling like they may have to choose between being trans and being religious, or some other aspect of identity. We want to highlight areas of resilience. If someone has already experienced and built resilience based on another aspect of their identity, how can they use those skills and those resources to support them in dealing with gender concerns, and vice versa. For Guideline 4 applications, this is, I think, the most important, honestly, is examining, interrogating our own personal beliefs, values, and biases in areas of privilege or marginalization. We all have biases. We're all sort of indoctrinated into a culture that poses certain, prioritizes or centers certain experiences over others. And so it is our job to do that kind of research. I like to say research is me search. So doing that work on ourselves and educating ourselves, not relying on the client to be the sole educator for us, and to really educate ourselves so that we have something to offer and not just take in a clinical encounter. So just a word about working across similarities and differences. Like I said, we want to be aware of our own identities. And those that we may not have thought about because maybe no one ever called attention to them because they sort of blend in with dominant culture. We want to refrain from trying to prove allyship. I kind of use as an example a savior complex because that is part of an enactment, I think, of not acting with our clients, but sort of taking unnecessary responsibility for them. We want to avoid assumptions based on our experience with trans folks and their communities. There's a lot of dual relationships that come up, and so really addressing that, especially when we share identities with our clients, maintaining humility, and taking time to learn from others who may be more similar to our clients. So looking for resources that might give us a little bit of insight into what our clients are experiencing. So here's our first clinical example. Dr. Payne, a white cisgender man, meets with Dusty, who uses they, them, and their pronouns, a 28-year-old African-American non-binary trans woman. Dusty is seeking support in coming out to their parents. Dr. Payne starts to get into a theoretical discussion about the contradictions in Dusty's gender identity. Dr. Payne complains, all this newfangled non-binary stuff and labels, I can't keep up. These are all true stories. Dr. Payne then starts to ask questions about who Dusty is sexually attracted to and whether Dusty is heterosexual or homosexual. Okay, so what's wrong with the situation? There's a lot wrong. I'm just going to skip to the next question. But how could Dr. Payne take a more affirming stance, or how could this be a less painful experience for Dusty? So we're going to, sorry about that. We're going to the first question, or second question. So which of the following? Educate Dusty about non-binary versus binary identities, engage in self-reflection regarding his own identity and biases, address Dusty's concern regarding disclosure with parents, all of the above, and options B, C, and D. So you have about 10 seconds to fill this out.
Just a few more seconds.
Hopefully you don't hear my dog drinking water in the background.
Okay, I'll wrap up this poll. Here are the results.
Okay, so the correct answer, so let's see. Most of you chose the last one, options B, C, and D only, which is the correct answer, and I'll tell you why. The first one is that And just so you know, my survey questions on my slide had to get shortened for our poll. And so there's a little bit of a discrepancy that we were working with right before we started. So that actually could have shifted your answers, of course. You know, Dusty has already come in and said, this is who I am. And it's not really Dr. Payne's role to say, you know, you have to choose one or the other. And this is what non-binary is versus binary. The second one we shortened to engaging in self-reflection. Yes, we want Dr. Payne to engage in self-reflection. And C, address Dusty's presenting concern. So we really always want to center the client's request and what they're asking for. They may or may not be asking for something we think they need, but we always want to center that. And so the correct one, this survey question is a little bit messed up. The correct answer really is B and C. So sorry, it's kind of a trick question. But, you know, something to highlight in this example is that, you know, there can be some questioning about, like, how can someone be both identified as a woman, which is seen as a binary identity, but identify as non-binary? And there are people who identify as non-binary trans women and non-binary trans men, and there may seem to be a contradiction, but there isn't for a lot of people, and we really just want to center their kind of self-identification and self-determination there. You also see that Dr. Payne makes an error around saying, oh, this is all newfangled stuff and I can't keep up, and really just kind of getting frustrated rather than being able to roll with what's going on, and then asking all these questions about sexual orientation, which may or may not be really relevant to what Dusty is asking for, and it's not really relevant to the presenting concern. Okay, so moving on. We're going to guidelines 5 to 7, stigma, discrimination, and barriers to care. So really these all hang together fairly nicely in terms of 5 being about just recognizing the stigma, prejudice, discrimination, and violence that affects trans folks, being aware of that, and that includes within healthcare and mental health care. Guideline 6 is recognizing institutional barriers and helping to establish affirming environments. So we get to play a role in that, not just say, oh, that's too bad, but actually actively acting with our clients and on the behalf of them in terms of helping to create more accessible environments. And then 7 is understanding the need to promote social change and reduce the negative effects of stigma on health and well-being of trans folks. So here are just a few barriers. We could spend a whole webinar talking about this, of course, but you know, trans folks face many barriers. They're all interconnected, and they all lead to a number of health disparities. And there is, you know, many trans folks don't actually seek healthcare because of how horribly they're treated, you know, so at least about a quarter of trans folks avoid going to the doctor because they're worried about discrimination. And so we really do have a lot of power in our role as mental health providers to provide a corrective experience and to create more affirming environments. So just some applications I want to name are to name and facilitate emotional processing related to stigma, discrimination, barriers. Create a safe place where people can talk about these things. Aid clients in recognizing the resilience they already have and continuing to build upon that. Taking action to reduce barriers. Referring to affirming community resources, and that includes doing the research to make sure that if we're making a referral, we know it's one that we can trust. I've seen that happen a lot. Oh, well, I'll send them to this, you know, treatment facility, and they experience a lot of transphobia and barriers there. So really doing the research ahead of time, and providing training or advocacy in school settings. Guideline 6. This is about our environment. So think things like resources, brochures, decorations, our paperwork, our EMRs, our restrooms, our facilities, just really kind of trying to take a lens to it and thinking, is this actually affirming and accessible for people of all genders? Guideline 7, getting involved in advocacy groups, getting involved with things that can affect policy change, providing resources for name and gender change, such as, the Transgender Law Center has a great resource called ID Please, and it really walks people through name and gender change and that process and demystifies it for trans folks. We often write letters of support for surgery or hormones. Now, this is something that does require more training, and we're not getting into that today. And of course, letter writing is very controversial. There's a lot to that, but when we do write letters, it does help people, even if we don't always agree with being in that position. But it does help people to gain access to the care they need. We want to understand the history of the mental health role in gatekeeping, because we've played a big part in that, and that's something that we need to own and actively try to repair, and seek to change protocols or standards of care so that they're more empowering and affirming. So I'll give you another clinical example. Dr. Ortiz, a Latina cisgender gender therapist, gets a job at a new trans health clinic. She notices that the demographic forms in electronic medical records only allow for a binary gender option. She notices that all trans patients are required to be in 1 year of therapy before accessing any gender-affirming medical interventions. And then she notices some medical and mental health providers using terms like demanding, difficult, and defensive to refer to trans patients. So the next survey question is, how could Dr. Ortiz advocate for more affirming practice in the clinic? And that's the next survey poll. Here we go. So the first one should say advocate for fill-in gender options, or at least multiple non-binary options. A few more seconds.
Okay, most people have responded. I'm going to close the poll.
Great. So most of you chose all of the above, which is correct. We want to do all these things. Advocate for the fill-in gender options, especially, I think not just in a trans clinic, in all healthcare, that would be ideal. But especially in a place where we're saying this should be a safe place for you, and then to have someone encounter that can really create some anxiety. We do want to educate other providers about the history of exploitation and gatekeeping and reasons why trans folks feel nervous seeing us. And I never assume that someone should trust me immediately, because I am part of an institution that historically has exploited and still does exploit trans folks. So really being aware of that position and that power that I hold, and educating other providers that, trans folks, we don't deserve trans folks' trust. We have to earn it and demonstrate it in action. And then the last one is call attention to the outdated standards of care. So previous standards of care require that trans people be in a year or in a certain length of time of therapy before accessing medical interventions and getting a letter. That is no longer the case for the Standards of Care 7. So this really sort of highlights how important it is to stay up to date on current standards of care, and that's from WPATH, which most medical systems do use for sort of evaluating, assessing, and referring for gender-affirming medical interventions. And so we do not require all trans people to be in therapy before accessing medical interventions. And so that is something that Dr. Ortiz could do to educate the clinic and say, hey, let's get more in line with current practice. So moving on. Couple of guidelines are related to lifespan. So one is related to youth, that's guideline 8, and one is related to older adults or elders. And for youth, some applications are staying up to date on the literature regarding trans youth, because there is quite a bit out there, and not all of it is actually, I would say stay up to date and also be really critical about the methods and how the research is being done, and looking for what is actually centering trans voices and affirming. Being transparent about our approach, providing psychoeducation and support to parents, refraining from reinforcing the idea that all trans people know they are trans from a young age. I like to joke that, we like expect people to know when they're in the womb, and that's like not the case for a lot of people. Some people know and can verbalize at age 3, some people not till puberty, some people not till early adulthood, and some people not until way older in life. So that is sort of a myth that all people know from a young age, that they're sort of in the wrong body, if you will, that kind of narrative. We want to understand that some young people will want medical interventions and some won't, and that these interventions aren't an option until puberty. So typically there are not surgeries being done on young pre-pubertal youth, and hormone therapy and blockers can't actually be started until puberty or until what we refer to as Tanner stage 2. We support the exploration of medical interventions when appropriate, and that includes the impact on reproductive options as well. And that's a big question around working with youth. Of course, can't get into the itty bitty details of that, nitty gritty details, but if this is something, if you work with youth, there are a lot of great resources out there to try to better understand how to work with youth. I often point people to the work of Diane Ehrensaft, and Gender Spectrum as well as an organization. So guideline 9 in applications, we really want to help older trans folks in developing social networks and reducing isolation, validating choices regarding disclosure, outness, coming out, things like that. Those are culturally loaded concepts, and some people will feel safe disclosing and some people won't. Some people are no disclosure, some people are low disclosure, and I choose these terms over using terms like passing or not passing, stealth, or something like that. We want to be mindful of generational and cohort differences, such as the age at which someone came out or started to transition, the era, what was it like in the 70s versus the 2015. So really, knowing that has such a huge impact on how people are conceptualizing their gender and the possibilities for transition or not transition, and aiding in exploration of some of the end-of-life concerns that can come up for older trans folks around, safety and care and medical support. So here's our third clinical example. Jess is a 12-year-old Filipinx trans masculine client, uses he, him, and his pronouns. His parents are divorced. Mom is supportive. Dad was supportive. I'll give context. This happens a lot. Dad was supportive, but through the divorce, recently withdrew support, and it's a point of conflict with mom. So it really is a parental conflict enactment, or, that is sort of bringing in Jess's gender. Jess is very anxious about developing secondary sex characteristics and would like puberty blockers. He's experiencing increased social anxiety, withdrawal, and gender dysphoria. This is a pretty typical picture that I've seen. And sometimes we also see withdrawal from school or school refusal as well. So the next question is, how might you respond if Jess was your client? The first one is meet with both parents and provide education about family support. Then we want to, the B is work with mom, ignore dad, and refer Jess to an endocrinologist. C is alleviate gender dysphoria before referral for medical interventions. And D is all of the above.
Sorry for the spelling errors and the answer choices here. All right, just a few more seconds. I'm going to close the poll. Here we go.
So the majority of you chose educate parents about family support, and I'll go over why. So, I think that it is so important for parents to know what a protective factor it is to have familial and community support, and it makes all the difference sometimes in terms of emotional well-being and whether someone can actually even stay alive at times. We know that having family rejection is a huge risk factor. A great resource is the Family Acceptance Project, but all the research really points to, not just for youth, but for older trans folks, that social support, I mean, it's kind of a no-brainer, but social support really does help to not only provide resilience, but promote better well-being. B is work with mom, ignore dad, and refer to just to endocrinologists. So this is a little bit of a tricky answer because, or option, because if they both have custody, then they both have to consent. I could be wrong, but pretty much in most states, if there's joint custody, you need both parents to consent to treatment. And also, just ignoring dad could actually polarize things more and create more barriers to just feeling supported. And so we would love to continue to include dad and not just ignore him. C is to alleviate gender dysphoria before referral for medical interventions. So the medical interventions that trans folks seek are actually treatment for gender dysphoria. And so we can't actually, typically, we can't cure or alleviate the gender dysphoria in order for someone to seek medical interventions. And what I'll say on top of that is that a lot of trans folks experience mental health concerns such as anxiety and depression or eating disorders or any number of things. And sometimes medical and mental health providers are mistakenly believe that all of these mental health concerns need to be treated and go into remission or, sort of before someone can seek medical interventions. And really, there's no way to tease apart what's depression and what's gender dysphoria. The current standards really state that mental health symptoms have to be reasonably well controlled. And that's very vague, of course, but it really is unrealistic to expect someone to have zero mental health concerns because they're also in an environment that does not set them up. When I say environment, we're in most folks are experiencing some form of stress related to the environment not being supportive or fully supportive of a trans identity. And so, it's these interventions also can be helpful. There is research showing that there are a lot of people whose mental health concerns actually they don't always go away. There are going to be trans and cis people with depression, anxiety, all these things, but that these medical interventions really do help quite a bit, a fair amount of the time. So the correct answer is meet with both parents to provide education. So the next section is assessment, therapy, and intervention. So guideline 10 is trying to understand how mental concerns may or may not be related to a person's gender identity and the psychological effects of minority stress. And then guideline 11 is recognizing that trans folks are more likely to experience positive life outcomes when they receive social support or trans affirmative care. So, our previous example actually touches on these guidelines as well. And of course, these guidelines are all completely interrelated. But we divide them up because, in each section there's a rationale and application. So we sort of divvied it up based on, how we could speak to the support for each guideline. So something just to say about co-occurring clinical concerns. There may be an increase in mental health symptoms for clients presenting with gender concerns. And there are some explanations for this co-occurrence. There may be no relationship between the gender concerns and whatever the other thing is, like panic attacks or the eating disorder, the gender concern may lead to symptoms, so via gender dysphoria or minority stress. So I see this a lot in my work in eating disorders. Yes, there is a lot of interrelationship there, but not always. Sometimes there's a co-occurring condition that mimics a gender concern. I would say this is fairly rare, but something that we've named. So it's very, if someone says that they're trans, I just believe them. And what we don't want to do, and I've seen a lot of providers do, is say, well, I don't know if they're really trans. I think this is just this instead. And I mean, that also includes people who are neurodiverse or, on the autism spectrum, as oftentimes they're not believed. And it is possible for someone to be both autistic and trans. And I shouldn't have to say that, but unfortunately, that is something that happens quite a bit, is that the gender concern is minimized or not validated because of some other mental health concern. And then the clinical concerns may be independent but influence each other and could be simultaneous. So, and then just a word about family support. We do see positive outcomes related to support, but families often are very confused and lack information. There's both covert and overt prejudice within families. And then family members also feel scared and are worried about rejection themselves based on transphobia or anti-trans bias. So we really want to explore ways of helping clients to connect to communities and resources that provide social support and foster development of healthy identity and resilience. And I think this could be family of origin work, but sometimes when family of origin isn't supportive, because some will come around and some may never come around, we do really want to validate family, like family of choice, and any sorts of communities and supports that trans folks can benefit from. So a couple applications, or some applications for these, are to educate oneself about common mental health concerns and overlaps, refrain from underemphasizing mental health concerns, identifying external stressors and sources of dysphoria, and learning about how hormone therapy and mood concerns may interact. And guideline 11, we want to emphasize an affirming stance and approach to care, assist in building supportive social networks and communities, assist in navigating social transition and disclosure. Sometimes that's underemphasized. There can be an overemphasis on medical processes and for forgetting that there's this whole emotional realm that people are navigating, emotional and relational realm. And then providing education and care and support to loved ones. Guidelines 12, 13, and 14. So 12 is about understanding just how sexual and romantic relationships might be impacted or impact gender identity and concerns. 13 is about parenting and family building. And 14 is about interdisciplinary care. And, I've never worked in a field before that requires so much interdisciplinary care, which is really wonderful. I get to work with so many different kinds of people, and it's actually really fascinating because we're all trained so differently. But we do so much work with other professionals. So some of the applications for guideline 12 is to support and normalize the process of exploration, fluidity, or new attractions. For some, not all trans folks, that is very much part of a transition process, with or without medical interventions. We want to assist in relational concerns and shifts, help partners, couples in renegotiating dynamics and boundaries of sex and intimacy, and creating groups for partners or opportunities for partners' own process separate from the trans person, because sometimes they need a separate space, and the trans person shouldn't always have to be subject to or responsible for the partner's process. Guideline 13 is we want to basically just help people to explore fertility and reproductive options, in the context of transition-related goals. So knowing, how hormone therapy or how top surgery might affect certain options, providing education about the many ways that trans and queer folks can build a family or become caregivers. So really trying to be careful to not impose more like heterocentric ideas or values about family building, which I've definitely seen quite a bit in trans health. Maybe making assumptions that everyone wants to procreate, or that is like something that everyone should do, or that everyone should birth a child. So these sort of, or that it's, two parents should also always be involved in this sort of thing. So a lot of biases come in when we talk about family building. And facilitating disclosure with family members. So this guideline is not just about family building for future children or offspring, but also how do you navigate and negotiate, relationships with kids that you might already have. And then in guideline 14, we actively collaborate with other healthcare professionals, surgeons, physicians, social workers, electrologists, speech therapists, nutritionists, clergy, attorneys, you name it, so many different people that we can interact with and partner with. And I do a lot of education to other providers, because they may or may not have experience working with trans folks or getting education about trans folks, but they can really benefit from in their practice from having this kind of information that may or may not be accessible to them. And we want to challenge barriers to care. So in my collaborative work with other professionals, I have encountered barriers and a fair amount of gatekeeping, and we can educate people about this. So, an example is, there's so many examples. Just the basic. Just the basic is, hey, you don't need to use the person's legal name to refer to them. Some people believe that, like, some healthcare providers believe that by law they're legally required to use the legal name, and we don't do that. We don't require that for cisgender folks either. And so just saying, hey, we always use the name and the pronoun that the person is asking for, regardless of what they look like, regardless of what their gender marker is or what their legal name is. I have this conversation just about every day. Okay, that leads us to our next clinical example. A potential new client calls your practice and reports wanting to work on relationship issues with their partner. They mention wanting to work with you because you work with trans people. So this is very, very common, the sort of call I get in my private practice. So what should you be sure to do during the first session? A is take a thorough gender history. B is refer partner to a support group. C is decline therapy and write a surgery letter. And D, that's D. And then the last one is assess clients presenting concern. Oh, this poll question got a little bit wonky as well, but take your best guess.
A few more seconds. Okay, I'll wrap this poll up. Last answers. Okay.
Okay, great. So the correct answer is assess clients presenting concern. So I will speak to some of these answers. So the person is calling and saying that they want therapy. We have no idea whether whether gender is actually a presenting concern. And so we would not take a thorough gender history. If the person, and I like to actually put out there that even when it is a presenting concern, I don't always do a thorough gender history during the first session. So the question is, what should you be sure to do, like no matter what, during the first session? And gender histories are a sensitive topic, and oftentimes medical providers are listening, medical and mental health providers listening for a pretty canned narrative of what it means to be trans, and so asking sometimes what I think of as silly questions, because I think of it as, let me ask questions that actually make a difference in my intervention. And I'm not asking questions to determine whether someone is truly trans or not. So a person may offer up information because it's healing to them to share their story, but I'm not going to ask questions like, did you play with dolls, or what kinds of toys did you play with, to determine whether someone was truly trans as a kid or not. That's just as an aside, something I feel fairly strongly about. And so we don't necessarily take a thorough gender history during the first session, and especially when we don't know what the presenting concern is. We don't know if the partner needs a support group. Partners really do benefit from support groups quite a bit of the time when they're struggling with a loved one's transition, but we actually don't know if the relational concerns have anything to do with gender. They may be like, we have a traditional sort of pursue, withdraw dynamic, and then we do couples therapy and proceed as usual. And so we don't know if gender is the main concern. So the ones about letters and surgery, the person never said anything about surgery or a letter. They did say they wanted a trans affirming therapist, but this is a very common call that I get, and people say, I say, why did you ask, why did you seek me out? Well, I was looking for someone who was trans friendly, even though I'm not here to talk about my gender. I just wanted to make sure that that wasn't going to become the focus, because that happens quite a bit. If there's a therapist who's not very trans affirming or trans knowledgeable, then they'll focus in too much on the gender when it's nothing is related to the gender concern. And so the correct answer is really to assess the presenting concern and the extent to which it is related to gender. It might be very related, in which case then we'll come up with some recommendations and resources, but it may not be. And so no one really wants to call into a therapist and have their gender be completely focused on. The parallel I draw is, if I call and I say, well, I would like a therapist who is, kind of familiar with Asian American values or communities or cultures, then I don't want the therapist to just quiz me on my Asianness the whole first session. So yeah. Okay, so let's move on. I am trying to move pretty quickly here, so there's some time for questions. So the last two guidelines are really just about research and training. So we want to use research, be careful about interpretations, and conduct research in a way that is trans inclusive and affirming. And we also want to engage in training if we're training students or trainees, including trans curriculum. So that is my timer to stop talking. I'm going to keep going for a minute. So we want to, try to make all research, not just trans-specific research, trans-affirming. And we will also want to conduct research that does increase the knowledge base that we have about trans communities. We want to be careful in making interpretations, including LGBT research, because sometimes the T is silent, as we all know, and there were actually no trans people involved. And we want to engage trans folks in research, so it really centering trans voices and being respectful of how we go into communities that may or may not be our own. And then in terms of applications, we want to infuse gender identity into all education, not just 1 week we're talking about gender in an inclusive way, and then the next week we go back to just talking about cis men and women and sexism. Use the guidelines. Encourage basic competency for all mental health providers, not just people who specialize, and create opportunities for advanced learning for those who do want to specialize. To be determined, but we will be offering another webinar on training specifically, so do stay tuned. And now is time for questions, and good. We have 10 minutes.
Yay!
Yay!
And this Really wonderful. I do have a handful of questions to share with you and see if we can get through some of them.
Great.
Working my way through them. One person asked, what is important to know about hormone therapy and interaction effects on mood?
Oh my gosh, this could take a really long time, but I will say that we don't have clear information about the effects of hormone therapy on everyone. There's sort of more anecdotal sort of reports. Some people believe that that hormone therapy, because someone is kind of coming into them, it's helping someone to feel more comfortable in their bodies and in their lives and feel more seen and in who they are, that it can improve mood and alleviate some mental health concerns. In terms of the hormone, so that's more of kind of a situational environmental, so sort of like a effect. But in terms of hormones, and the actual sort of physiological effects, some people do find themselves feeling a little bit more moody. Some people, there are some folks who, if they have a previous history of bipolar or mania, there are times when testosterone can trigger a little bit of mania. I've seen people have decreases or increases in anxiety or depression. And of course, it's really hard to tease this apart from social aspects or environmental aspects, because someone may go on hormones and start to feel great, but they're also entering into a space where people are starting to notice, and they may be in a middle space, and they're not legible as male or female, and so they may be encountering more stress based on that. So yeah. I could go on, but
Yeah, no. I have two more questions that are pretty burning here. One is, do you have any general advice for people who live in areas where there aren't any physicians to refer to for gender questioning or trans kids, especially younger kids who may be interested or considering pubertal blockers? Maybe someone who provides telemedicine or consultation. Any feedback for that individual?
I think that's a little tricky because, well, I mean, oftentimes providers have to operate within their statewide jurisdiction. So I don't know. One thing to think about is to see if there are providers who are at least open, like have a more affirming stance, but they don't have knowledge, and then to support and encourage those people to go to conferences or get continuing education so that you can build the capacity of a system to hold trans folks and youth.
Great, thank you. And next question is, what is the current best practice regarding the need to define a trans person seeking insurance benefits for medical procedures, having a gender disorder recognized in the double bind of saying one is a mental disorder or not mental?
Yes, yeah. So walking the tightrope, you have to be not too sick, but not too well. So gender dysphoria is the current DSM diagnosis that is required to justify medical necessity for gender affirming medical intervention. So of course that's challenging because not all trans people have gender dysphoria, but it is required for that diagnosis is required to seek medical care and for insurance to approve it. And of course, insurance policies vary in terms of whether they'll cover any gender affirming medical procedures. But yeah, we're unfortunately at a place where these are still, well, I don't know. There's a lot of, I'll just say there's a lot of controversy. Some people argue that we need this diagnosis so that people can gain access, and other people say, no, this is continuing to pathologize trans experiences. But yeah, and so as part of seeking interventions, people do need to have a gender dysphoria diagnosis. Sometimes we can get around that with something like congenital absence of cervix or something like that, but most of the time, if it's people do need a gender dysphoria diagnosis.
Great, thank you. We have a bunch of people asking about resources. One person asked about assessments. How do you recommend, or can somebody use MMPI or the PHQ-9 with trans clients if they're not normed on trans people?
Right. There is not, I can't think of it off the top of my head. There is an article that Cole Kilmeyer wrote with some folks about this. This is not my area of expertise. I tell people to be very cautious when interpreting results and using norms. And I may want to look at both, like if it's normed for men and women, I may look at both. I don't assume that someone fits in either. And the other thing I will say is that I really don't think that MMPI or other personality assessment measures like that should be used to as gatekeeping for people seeking surgery. So I've known of some psychologists who have said, oh, I'm going to give the MMPI to anyone who wants genital reconstructive surgeries to just, kind of predict whether they're suicidal. And I'm thinking, you don't need the MMPI to assess for suicidality. We can use our clinical skills as well. So I am very suspicious and cautious about giving, really thorough batteries to people. We really just need to believe people when they say who they are.
Okay, great. I have two more questions if we have the time. In anxiety treatment with a trans adolescent, how do you balance reducing avoidance behaviors and keeping them safe and validating that they do face very real threats in their environment?
Yeah. People are trying to avoid as a form of survival. And so, I think it's really tricky. We want to affirm and validate the experience and how hard that is, and affirm that this is a choice they're making that is about taking care of themselves, but also maybe do a little bit, I think, about like motivational interviewing and seeing also what are the setbacks and how can we provide more resources and build resilience, as well as work with someone to figure out what is really challenging and how do we as psychologists step in and advocate to start to shift those environments to make it a safer space for people when possible.
And maybe we have time for one more before. San, do you have one more slide there with the URL for the evaluation?
I don't have the one with the URL for the evaluation. I have
an email will go out. Okay, an email will go out with information about the evaluation, which is the second part for this, the CE. So for those questions that we didn't get to, we have a list of your questions. We will take them down and we will make sure that we get back to you with some answers where possible for those questions. Please be sure to go to the Committee for Sexual Orientation and Gender Diversity, as well as the Division 44 on American Psychological Association's web pages. There are a ton of resources available online there. We will also include some links to some major resources. I can see here that a lot of people had questions about youth and teens and managing care for youth and teens. So we'll include some resources there. And we will also make sure that copies of this, we recorded this webinar, so recordings will be sent out to attendees, as well as a copy of the slides in PDF format. We hope this presentation met your expectations. Make sure that if you want that continuing education credit, you complete the evaluation within 24 hours. You should get the email very, very soon. The evaluation was created with Survey Gizmo. It's not live here on the screen, but once you get the email, just copy and paste it into a browser window and you should be able to complete the evaluation. Ron, do you have anything else you'd like to say before we sign off on this webinar?
I just sent out the link to the evaluation in the chat field. So if folks want to go ahead and copy that right now, then you'll have it. Other than that, I just want to thank everybody for your participation and let you know that we had about 350 participants as a steady number throughout the presentation. So I think that just speaks to the hunger and the need for this kind of information. And I just want to thank the presenters and thank you, San. Thank you, Seth.
Thank you, everyone.
And yes, thank you, everyone. We appreciate it.
Have a wonderful day.
Take care. Bye.